who is our last positive pause before our panel about policy in this time of real crisis. I was so lucky to get connected to Senator Friedman, my collaborators at NAMI Mass, and she has been a steadfast advocate who gets it, who understands, and has been a leader to ensure that mental health is healthcare. She's put out a wonderful act, if you haven't read it, the Mental Health ABC Act, that lays out key strategies for us to get closer to mental health parity. And she is also just someone on the ground doing all the work that's needed to make that happen. So we're so honored to recognize you. Congratulations, Senator Friedman, and thank you for all of the work you're doing to ensure resources right now, free up emergency funding, and also keep mental health on the radar. And we'll also be joined by Chris Friese. Hi, thank you so much. That's nice to be able to see. Good morning. Congratulations, Cindy. Thank you so much for taking the time. I just wanted to introduce our last panelist, who's Chris Friese, who is a nurse and researcher who is dedicated to understanding what quality cancer care is and making sure that everybody has access to it, also with being an advocate for frontline clinicians to make sure that they're safe at this time. Thank you all for being here.
Thank you. And thank you so much for the recognition. You know, I have to be honest, it pales when I listen to people like Ahmed and Asabel and the people who are actually doing this work on the front lines. It's, you know, I'm happy to do what I do, but I never forget the people who are actually providing treatment and working through all the barriers we put in front of you to provide treatment to people who need it. So thank you to all of you.
Thank you, Cindy. That's very kind of you. You're gonna make me cry. So sorry.
So I guess maybe I can start us off with a question to kind of bridge up from Ahmed's speech and some of the questions that are coming up right now. You know, this is obviously an unprecedented health crisis, and it's just, we're here in this moment. I think that we're also anticipating an increasing wave of mental health needs to come. And we know that the people that are hardest to reach may not be the people who have Zoom. So I just wanted to think with you about if we're going to be able to hold on to any of these advances in telemedicine that we've made over the past month. Is there a possibility to work in still getting reimbursement for phone services, creative initiatives and telehealth pilots into the great work that you put into the Mental Health ABC Act?
Sometimes sometimes it's hard to get things done. It's often hard to get things done. But it's really also hard to go backwards. And I think in two areas, I think we're going to see a real push to continue, and that is in telehealth and in scope of practice, especially around advanced psychiatric nurse mental health workers. And so I think as we see how this is working, it's going to be very, very difficult for the insurers and Mass Health to pull back on what they've done to support telehealth. Now it's going to be a fight, but there's going to be an awful lot of data that we've captured that is going to tell us that this is not only efficient, but it's good practice. And I think there's, where people didn't understand exactly how it was working, now there's just an entire segment of the system that's using it and depending on it. And we're going to need to continue that. And I think it's especially going to be true in the areas of behavioral health. Now, some of it's going to be an argument, is the phone the same as, as talking to somebody? Is asynchronous the same? Should we continue with asynchronous? Or, we're going to have those battles, but I think we're going to have a much better roadmap and an argument on why we just need to keep doing this. So I am actually hopeful around that. And I think we will see it, at least a lot of advances, maybe not all the way, but I think we'll see it.
Yeah. And maybe we should just take a step back and ask you kind of what you're, what you're really thinking about right now from where you're sitting in the state Senate, in terms of like, what do you think are the key steps that can be taken at a state level to try to especially get care to the most devastated communities? We can talk, also about the essential mental health issues there, but I'm just wondering, I've seen like some important work that you've done, to, free up, like, try to prevent evictions or to try to free up other money, emergency funding to towns. I wondered what you think. Like, I think sometimes for me as a clinician, it's a lot of different policy issues, and I'm never sure what's like the key actionable changes that'll actually get to people.
The way I look at it, because it's so overwhelming, and I think to take a step back, what we're seeing in a lot of what's going on is the incredible fragility of our infrastructure. That we have had issues with healthcare, access to healthcare. We've had issues with how we take care economically of the most vulnerable. We've had issues with our transportation system. I mean, it goes on when you look at all the big systems. And what we're seeing here is the incredible fragility of it, and how when you have this kind of situation and you have systems that have been ignored for so long, they can do nothing but bend on the weight of all of those years of not paying attention, right? Of not funding, of not, saying, hey, we need to be sure that we have good infrastructure in place. And some of that is because we're humans and we can't think about something that's 2 steps ahead of us. We're all about the now and the moment, and we react to things in the moment. And some of that is just our, that we don't take seriously what it means to have a public health system and what it means to have a full, robust healthcare system for everybody. And so we're seeing a lot of that come out in this epidemic, unfortunately. And you really see it around long-term care, how our seniors are being impacted. I mean, that's a system that's been on the brink of, of complete failure for a long time. And now we're seeing what happens. So I look at it as saying, okay, are people getting the healthcare they need right now? Are people having the essential pieces of life to keep them going, a shelter, food, and are our systems being replenished in a way that we can keep going the next step, the next step, the next step? So that's why we've done housing. That's why we've done the healthcare. We've done the telemedicine scope of practice. Now we're doing liability. We're working on the standards of care. They're all sort of in the moment. Housing, we're doing a housing bill that was supposed to come out yesterday, preventing evictions and foreclosures. And then we're working on the safety net. Okay, so that's kind of what we're doing now. And we do it to try and stay 1 step ahead of what we think is coming. In the behavioral health space, we have not seen it come yet, right? Like, you all know, if you look at admissions are down, people aren't going to emergency rooms.
It's because we're trying to keep them all out of the hospital.
They're afraid to come to the hospital. They're, admissions are down in the psychiatric hospitals because people just aren't showing up. Well, we all know what's going to happen as soon as this sort of flattens out. So that's I believe in this space, that is what we need to be looking at right now. What do we need to do?
I think that's really important. Before we also ask Chris, I just wanted to bring up a question that's coming from Deborah Shields and has been raised in our work groups, and I know by many people over the past few weeks, about the Massachusetts crisis standards of care and the concern that that people with mental illness, disabilities, that their lives would not be equally valued if we were considering estimation of long-term life. So I just think that's such an important human rights issue.
Yep.
And I wondered your thoughts on potentially revising that standard of care, or what your thoughts were.
So this has been a great concern. We were very careful to keep the liability bill somewhat separate from the standards of care, because one was the liability was trying to address an incredibly difficult problem right now, which is bringing people back into the system so that they could work in the field hospitals and in nursing facilities, et cetera, et cetera. But we knew at the same time we had to do something about the standards of care. People are right. There are real issues with them. And we worked very, very hard with the administration. My understanding is that the administration is, if not today, very, very soon coming out with a revised crisis standard of care that addresses a lot of the issues that the valid issues that people have raised. And also the Senate and House is convening a group to look at disparities, to look at what we can be doing to make sure, number one, we track how people are being treated across our Commonwealth, in the urban centers, in the most affected centers, what we can do in the short term to address these issues. And I know that I am working with the Mass Health Association to try and figure out what's the next step in making sure we address places like Chelsea and Lawrence and Holyoke and, you know, our inner cities, where we have so many people who we are so desperately dependent on, you know. So it's not only, you know, for them, it's for our whole Commonwealth. They are so important. They are so important to getting our work done. And so there's a lot of effort. So I think between what the House and Senate is going to do, and what the you know, and that the administration has heard loud and clear, and they're working on the standards of care, I think we're going to make some progress. We can't fix 100 years of disparities in treatment, and right, but we can start to fix what's in front of us, and that's what I think we want.
Yeah, and I think it can shine a light on what is there. I wanted to ask Chris for your thoughts too.
Sure. Well, good morning, everyone. It's great to be with you virtually. Oh, good morning, everyone. It's great to be with you virtually. I want to. It's an honor to be on this panel and to follow Senator Friedman and her leadership. Clearly, the example of a citizen legislator who gets it and is committed to the work. So really honored to be here. I wanted just to, you know, I've been with you through most of the morning, and just some reflections. We need you all now more than ever. There's this sense that if you're not working in the COVID ICU, taking care of the sickest of the sick, that you're for some reason not the priority. And I think that's a mistake. And it's a mistake for the reasons that we just brought up, that we need this partnership that you all have worked so hard to create and nurture, to be the wall of defense for people who may not, as you say, have Zoom or be on social media or these other places. So the way I think to think about this for this community that you've assembled, this really robust virtual community from across sectors, is to do two things. One is to, I'm a researcher, so I'm going to start with data and make sure that your legislators and your local newspapers know the impact of what we're dealing with, the number of individuals who are at risk, the number of individuals, as we said, who you know, could be at risk in the future, those who are week to week on some of these essential supports that don't make the front page but are so essential. So it's important to have the data for that. And then this consortium can really bring the narrative together. What I have found over my years in the Hill and also in DC and also in the State House is data with a compelling narrative and patience is the magic recipe. And I think, you know, Senator Friedman, you said it well. I mean, we have to deal with the immediate crises, but we also need to skate to the puck and where the puck is heading. And as you all have outlined, there's some real potential challenges. So the point is, don't rest up, track your data, track those individuals that you serve and those communities you serve, and start to tell those stories locally now, so that they are not forgotten later, so that when the time is right, you're able to bring this back up to the front of the conversation. You need to keep that steady drumbeat, because without it, we have the potential of losing this really important narrative that could be really damaging to a large sector of our population.
I couldn't have said it better. That is it in a nutshell.
I mean, I really appreciate you saying that, because I think that oftentimes people I had my internship, I'm a doctor, I can be of service, I volunteered for the RIC, and we questioned, does it make sense to continue to bring us together here, while we're doing virtual visits, and Amy and I felt it was important, because part of our work is to amplify the voices on the front lines and be that bridge. And we will record this and we will get it out there. We'll do our best. And I think Ahmed is such a force with getting narrative out there. And I think that right now for our frontline clinicians, this is an urgent crisis, a mental health crisis too. First, a crisis of PPE and physical safety, and next a crisis of just something that is unbearably difficult to endure. And so I think the reason why I felt that mental health stigma was so relevant here is just how hard I know it is for so many physicians and other clinicians to ask for help, especially when there is a call for acute service like this. I think we're doing a lot of things at Mass General, but I just kind of wanted to state that because I think that's related to your passion about mental health stigma, and I think we need to make it as easy as possible and as clearly integrated as essential care, essential to be good at fighting this pandemic. Not an optional thing. It's what you gotta do. Just you can't work more than 4 days and be of service anymore.
Kelly, if I could just add one other quick point on this. I think, for those, there's been sort of an ongoing debate as to whether formal healthcare systems should be engaging in addressing structural determinants of care. Some might call them social determinants. I prefer them to be structural because I don't think they're necessarily social. We can talk more about that. I know there's a lot of social workers in our group. It is very clear that if we do not address these structural issues, we're watching this, as the senator said, fall down right in front of us. And so you cannot disentangle these. It doesn't mean that every clinician needs to understand every single aspect of the structural issues that their patient or their communities face, but to ignore that and to not have that part of the solution is a recipe for failure. And that might be the greatest lesson we learn from this. There's an opportunity to learn here and do things differently. There's an opportunity with flexibility in Medicaid programs and other things to say, we're not going to let this happen anymore. We're gonna fix this now, so that this long tail of bad outcomes can be stopped. Because if we don't address these other issues and have the flexibility we need to meet the client where they are, then there's no point in doing what we're doing.
Absolutely. Did you want to add anything on that, or?
Well, it's an honor. It's an honor to be on the panel with Senator Cindy and Christopher. And I can't thank you enough, Kelly, really for inviting me to contribute. Well, I mean, I'm based in the UK. I mean, and I'm in London, and that's where the epicenter is of COVID-19. And we're fortunate because we have the National Health Service. We have universal healthcare, which is kind of free at the point of delivery. And I mean, now we're really starting to feel valued by society. And it feels actually like the government is doing all it can, which I think it might be contentious and controversial because concerns have been raised about PPE, for example, and testing. We're certainly lagging behind other kind of European nations, such as Germany, for example, in ICU capacity. I mean, notwithstanding some of the kind of the limitations, if you like, or the flaws. I mean, they're feeding us. There's a lot of, I don't know if you heard about Captain Tom, for example. He's raised £15 million for NHS workers. So they're putting us up in hotels, and we're actually starting to get the royalty treatment for a change. And I mean, all that kind of really does bolster morale From a kind of a perspective of someone who is experiencing mental illness and cancer. And I had a very long discussion yesterday with a close friend of mine, Dr. Charlotte Wilson-Jones, is a consultant psychiatrist at the Maudsley, and her area of expertise is psycho-oncology. And she said, Ahmed, please share with the people who are listening and who are watching the loneliness that those with mental illness and cancer are experiencing right now, and how isolated they are. I might be stating the obvious, but really can't emphasize this enough. And so I think we do need to take full advantage of digital technology, of social media, to try to facilitate that kind of social connectedness that we need for our mental health resilience. So yeah, those are just some of my reflections, and I hope that it kind of overlaps with what some of the other, what Senator Cindy and Christopher were saying, and what you were saying, Kelly.
Thank you, Ahmed. And I know Vicki is here from the Mongan Institute. It'd be wonderful if you have a question.
Yeah, and I just wanted to thank the panelists so much. This has been just for your ongoing work and also your comments. I've heard you, so I'm coming from a research perspective, and us within the Mongan Institute and more broadly, many of us work in population health and think about how we can kind of, support some of these important efforts that are going on through research. I know that the bridge between research and policy is not always as smooth as we want it to be, or the translation from evidence to action is, sometimes there's a little bit of a hiccup there. And I wonder, I've heard a couple of you comment on, the need for data, or sort of the power of data and connecting with some of these narratives and sort of patient stories. And I wonder if you could tell us a little bit more about what kinds of data would be most useful from a policy perspective to support, let's say, ongoing efforts around reimbursement for telehealth or other, peer support or other kinds of providers that we might be able to focus our efforts on now. There's such sort of this balancing act between kind of where we put our priorities, and I wonder kind of what are your highest priorities in this area that would support some policy efforts. Does that make sense
for you, Cindy?
That's a very tough question. I mean, so there's two kinds of data that I think are important to us, and I have not thought about this a lot, so I apologize for the muddledness of this response, but there's the data of what is happening now, right? Like, we have certain policies in place and certain requirements in place, and we don't often have a good visibility into whether or not that's happening. And that the really, really good example of that is parity, right? It was very, very hard for us to get any data, any real information on what kinds of, whether we were meeting our parity requirements, and the policy that we have that meant that mental health and behavioral health have parity with med-surg. So that's one kind of data that is really important, like what's going on now and how is it being played out, because that really informs the policies that we have in place and what we need to do to ensure that those policies are result in action. The second piece of the second data set that's really important is what works. Okay, like, things move in this area somewhat quickly, or maybe not as quickly as we want it to be, but things do change, and I'm never clear that I really know what is the most up-to-date thinking, especially in terms of mental health. I'll give you a good example. There's data, I believe, that's out there that says when you address mental health early on, especially serious mental health like psychosis, schizophrenia, bipolar, when you can have treatment for young adults early on, that has a real effect on long-term outcomes. I sort of know that, but I don't get information that says, here's the data around that and here's what programs work. So I can't go back and look at the system and say, are we in line with what ought to actually be happening to treat people? So that's the other piece of it, right? How do you make that connection between the data and research that you all are doing and what the information is telling you and what the best practices are, so that we as the policymaker know what we should be focusing on. So I think those are the two pieces that come to mind. I'm not sure that's helpful, but that's kind of what I think about.
Yeah, no, that's very helpful. And I think that, you know, the two types of data that you mentioned, there are, I think we kind of often focus on the second part of the equation, trying to understand what works, and we kind of have sort of tools and designs that we use to try to address that. I think some of the sort of real info on what people are doing and you know, what's really happening in the care setting, that is often much harder to get. And much harder to sort of figure out how to get people to sort of share more broadly or with the people who need to get the data. So I think those are two really important pieces of information that we need to be able to connect better to be able to pass that on to policymakers.
Kelly, could I answer that briefly?
Yeah, go ahead, Chris, and I'll go
Sure.
after Chris.
So, Dr. Fung, thanks for the question. So I'm a researcher, but I also spent time on the Hill as a staffer, essentially, for a year, and it was during the ACA repeal. I just give you a little bit of context. And so, you know, to me at the time, what was very, very useful, and I was trying to help research teams kind of put this together, to Senator Friedman's point, what's the current state? How many people, for example, have benefited from an existing program or policy? How many people are using that? And I don't know if Senator Friedman would agree, but also in the local context, how many in my district? How many in this county? How many in this city or state that I really care about? So that granular detail, which may not be the precise numbers that we're used to as researchers, but that sort of snapshot of here's what this looks like in my backyard, was extremely powerful. And then it allowed us to connect to the local newspapers, because then they picked it up, right? And so that's number one. The second point, to Senator Friedman's point on what's working, the researchers want the randomized clinical trial evidence. And particularly in this setting, that's going to be very difficult. And so my suggestion is, don't let the perfect be the enemy of the good. If we have an intervention that shows promise, that doesn't harm people, that moves from the status quo and moves it in a positive direction, that is worth sharing. And it doesn't necessarily need to be in the New England Journal of Medicine and published. A lot of the best stuff that we used was preliminary data that researchers were working on. I think the final piece is linking it to the narrative. So when we did an ACA impact report, we did a rural county impact report of the ACA, and then we had verifiers of people who had been on the exchange or been in Medicaid expansion in that county talk about how they were now able to get expensive meds for their kid. So linking the numbers to the narrative gives you that multimodal approach that, depending on the member, some members are very data driven and some members are a little bit more sort of narrative driven. And particularly in this space, the N of one story can be very, very powerful. So those are just some tips that I have. The final point I would make to the Senator's point is have a nimble time frame, because I worked on one bill for 4 years and it's now seen the light of day, and it came through this omnibus of the COVID stuff. It has nothing to do with COVID, but they attached it, and we had about a day and a half notice. Sometimes you need to work on a bill for 5 years, and sometimes for some unknown reason, it moves in a day. So you have to, as a researcher, it's not our nature, but we have to have a nimble posture to be ready to respond. And so if there are key things that you're working on, you need to kind of keep that relationship with the members going. What's this looking like? What do you need from me? That sort of dynamic state. It's not our comfort zone, but I found that was very useful.
Do you mind if I jump in there?
Please.
Actually, so my name is Bev Moy. I'm actually a medical oncologist and a health disparities researcher, and I've actually spent a good amount of time advocating at the Massachusetts State House and on at Capitol Hill. And there are many of us in this community who are interested in becoming more effective advocates. particularly with policymakers. And I get asked all the time, how can I best help or make a dent in it? Even the hospital leadership has tried to figure that out. And I think there are many things that I want to emphasize that Chris had just said. One is that we're lucky in this community because we have a champion like Senator Friedman who gets the landscape and can allow us to help be strategic in figuring out how to best forward things that are going to help our patients most. So what Krista said about being patient and being flexible, it's about timing a lot of times. Many of these things that we want to bring forward happen because something just occurred statewide that we may not be aware of, but people who are policymakers are, and you can pair things that work well. Secondly, getting to Dr. Fung's point about research and evidence, what I have found to be helpful is being that resource. So if there is an issue that's coming up and the lawmaker needs to have someone step in with a piece of data or with a personal story or with responses to questions that he or she is getting that is threatening to wreck a bill, I like being the person that's emailed. And I respond immediately because that ends up being a very big thing, being very timely, being available to volunteer time to go up to the State House or fly down to Capitol Hill and meet with the people that want to be met with. And when you put yourself out there, people tend to call on you more often, which is really great because it ends up helping you get the agenda across. And then something else that Chris said earlier, which I think is really important, is that we have a really important voice, right? Policymakers are doing the big things that are going to change, everything, change the landscape for everybody. But we're on the front lines. We're seeing what our patients are going through. And more importantly, we know patients who can tell their stories much more effectively than any of us can. So having that network of healthcare providers who can eloquently talk about what's happening and patients who are willing to talk about their
stories. Who are here too and are sharing their stories today.
Exactly.
There's a lot of power in this coalition. I really appreciate that guidance, Bevins, and Senator Friedman, you being here too, just because I think that many people want to kind of figure out how to get that frontline information and those stories. We have a coalition dedicated to gathering data and stories. And I call the Globe and they're like, yeah, I'm not really interested. And I'm like, you're not interested in people who aren't getting care and they're dying because they're being discriminated against. Like, that's not that interesting to me. So it's about timing and fitting it in with the scope of what other people are interested in. So I'm always happy to be a hotline and be practical. I'm a pragmatist. I have many people who are not getting care that need it and are being affected by like triple, quadruple disparities right now. So whatever's helpful. And I really appreciate the discussion. I don't know, Senator Friedman, if you have other guidance for us. I just wanted to state, I know everybody on the phone and who's called in, who's here, there are many people who have, who might identify more as patients or caregivers or other community members. So I just wanted to give you an opportunity to have your voice be heard.
No, I think you all did an exceptional job. I mean, Bev, you are absolutely right. Vicki, was a great question. Chris, the pointers were actually absolutely spot on. I think the only thing that I would add is it's important to know who is making the decisions. Okay, so there's sort of different levels of advocacy. And it's important for advocates to know who do I need to go to help, that are really in the mix of moving this along, and having people in the legislature, both state and federal, who can help you navigate that is really important, because all decisions are not made at one level, right? We all know that. And so knowing how to advocate and knowing who you're talking to, when you go to talk to somebody, you need to know who you're speaking to. I mean, when people come into my office and say, we really want you to pass S216, and I'm looking at them saying, I wrote that bill. It's like, okay, where do, come on guys, like, and I know advocacy is important, but it's just, if you can just take that little extra time so that people know who they're talking to. So, and don't waste your time coming to my office to advocate for a bill that I wrote, right? Just say, thank you, you're welcome by, right? Don't, so I think what everybody said is really true, and timing is everything. We did that telehealth bill. My team has been working on that telehealth bill for 2 months, and man, we could have put it out in 15 seconds. If the governor hadn't done it, we would have been right there. Same with scope of practice, So timing is so much part of it, and we are always looking for ways to stick our stuff into things that are moving, and we will continue to do that. But I guess I just want to say that this moment in time is so critical to stay connected with you, because I need to really understand what we should be preparing for. And that's what I want to be doing next week. I want to know, okay, what do we have to be paying attention to in the mental health space, so that we're ready when the curve starts to flatten, and and the hospitals have the ICU beds they need, and now we're seeing some moment of pause in the initial flood. We have to focus on mental health.
I think the question from the chat before we close is just, what data would help you to be able to go from kind of emergency measures to holding on to these innovative things that are happening to increase access to mental health care? Is there like kind of key data that you need, or?
Yeah, how many people are going to vote for the next president of the United States? That's the data I'd like to have right now. Because we are so dependent. Listen, we're running out of money, okay? The state is running out of money. We're doing everything we can to pay for the stuff we need. And there is no lack of people really, really caring. Even at the administration level, everyone, people are working so hard to try and fulfill the needs that everyone has. We can't do it alone. We can't. We just don't have the resources. And we need a federal government that is going to take this very seriously. They can print money. We can't. And so much of this is going to be dependent on the resources that we have. We got really bright, smart people. Okay, we'll figure it out if we have the resources. Charlie Baker was not holding PPE supplies in his backyard and not letting them out, right? He was doing everything he could to get PPE, right? We had a federal government that was working against us. So we really, really need to get the feds on board with us to solve this problem. And I'm being facetious, but at this point, I'm really, really worried about money. I think we've got, with all of you and other people, we can sit down and figure out what we need to do to drive our system so that we have some resources in place when we need them. And I really, really want to do that, and I have started working on it. So I invite anyone who wants to help me. I'm just worried about how we're going to get it done.
I think that's a reality. It's a good call to vote in November, which is just
Kelly, what if I could, what I would share, I think, in terms of data, the other point I would make is you don't need nationally representative data. If you work in a particular agency that serves a particularly vulnerable community, that is very valuable data. So we don't need this perfect national data set with every bell and whistle, but if you can get to the senator, in your community, we're serving X hundred people, and 25 of them did not fill their script last month because of out of pocket or whatever the issue is. That's very valuable data. So don't wait for that perfect data set to just fall into your lap. The thing I'm a little bit heartened about, and we'll have to see if this continues, is the multi-sector cooperation that we're seeing, where the payers are on the phone with the governor, on the phone with the hospital executives in the mornings, doing these, rapid huddles. What do you need? Who needs what? And I'm seeing a level of cooperation across sectors and partisanship and other things that is refreshing. It's not everywhere, but the question for us is, can we continue to nudge and nurture that for after the curve flattens? Can we continue to hold our leadership accountable to continue that behavior to address these longer term issues that are very close to us very soon? That could be a way to kind of break through some of the historic issues here, where you've sort of had different camps arguing over certain issues. This is in the best health of your community to get this right. And there's an opportunity to learn from that.
Absolutely.